Bismillahirrahmanirrahim. Our today's topic we want to make you to be oriented is heterotaxy. It is the related topic with situs is a terminology describing position of the organs in the chest, thorax, and also abdomen. It is assessed by the identification of short fissure of anatomical right lung. And we know the short fissure is dividing the upper and lower middle lobes of the right lung that is not present in the left lung. So identification of short fissure is very important to declare the right or left lung. And the next, the length of the bronchus. The right principal bronchus is shorter and straighter rather than the left principal bronchus is longer and it is inclined to the left more. And the ratio between the right principal and left principal bronchus length is between 1.5 to 2. Whenever the ratio between the two principal bronchi are less than 1, it is a part of heterotaxy, that is, there is issue is located in the situs. And the location of the gastric bubble is on the left. We usually see in the chest X-ray view that there is a large gas shadow seen under the left hemi diaphragm. So is the hepatic contour. We know the normal liver shadow is on right upper abdomen, and it is casting a dense opacity on the right hemi diaphragm, and the right hemi diaphragm is higher in relation to the left one usually. So let's talk about some situs issues. This is an X-ray chest PA view showing the cardiac apex to be on right side and the gastric bubble is seen on the left side of the abdomen, and the hepatic mass is seen on the right upper abdomen. So this is a case of dextrocardia with situs solitus. It means the heart is only rotated to the right, but the other abdominal organs are not following the same. It is usual normal location. And this dextrocardia is seen here with the cardiac apex to the right side, and the gastric bubble is seen here on the right side of the upper abdomen, and the dense hepatic mass is seen on the left upper abdomen. So this is a case of situs inversus totalis. This is a newborn baby X-ray abdomen and chest together in a plate with the cardiac shadow on the right side of the chest cavity, and the hepatic mass is seen on the left upper abdomen. So this is situs inversus. And in this photograph, you see the cardiac mass is on left side. But even there is an issue of situs, there is possibility of situs abnormality assessed by the direction of the nasogastric tube. You see this nasogastric tube is running from the neck, traveling to the chest on right paramedial location and leading to the right side of the abdomen. You know the esophagus is a left-sided organ in the thorax, and also it is entering the abdomen to the left side, reaching the gastric fundus. But here you see the nasogastric tube is running to the right paramedian location and entering the stomach on the right side of the abdomen. So there is an issue of heterotaxy running here. So you have to remain in our mind that Heterotaxy is a rare thing, but it is affecting our medical issues as the cardiac abnormalities are much more common in the heterotaxy and situs abnormally patients than the normal individuals. Next, we are going to discuss one thing about the cervical rib. This is an extra rib at the C7th cervical vertebra. This congenital abnormality representing persistent ossification of seventh costal element that usually resolves in the early development of the fetus. It is estimated as 0.2 to 0.5% in population. These are mostly incidental and it varies in size and shape. Sometimes it is present with thoracic outlet syndrome. And how can you diagnose the cervical rib? The transverse process of the cervical vertebra is directed to inferolaterally, and the transverse process of the thoracic vertebra is directed superolaterally. So we will get a transition of direction of the transverse processes at the C7 and 7th cervical and first dorsal vertebra seen in the epifield. Cervical rib can produce symptoms on occasion, and for the total rib assessment, MRI is the choice of investigation because the cervical rib has got an ostial part. We can see it in X-ray, and it has got a chondral or fibrous part even that is not seen in X-ray. And the total study should need an MRI if it is causing outlet syndrome. And this is the X-ray of the thoracic upper part and cervical lower part, showing the complete C1 vertebra and the transverse process of the first dorsal vertebra is directed superolaterally. It is superolaterally directed transverse process, and the inferolaterally directed transverse process of the C7 is seen here, and the small thin rib, the cervical rib, is attached at the 7th cervical transverse process. Here you can see it up to here, and this one can be traced up to here, up to the clavicle. And then next is the thoracic outlet syndrome. The compression of the lower trunk brachial plexus, the subclavian artery or lower sympathetic thoracic chain produced when these structures are encroached by the cervical rib and scalene muscles. The lower trunk brachial plexus compression produces weakness of the muscles around the hand and at the base of the thumb. This is the lower trunk brachial plexus compression. And whenever there is compression of the subclavian artery, produces positive Adson's sign, where the radial pulse is lost in abduction and external rotation of the shoulder. But this is a non-specific test, but is found in cervical rib producing thoracic outlet syndrome. The compression of the sympathetic chain may produce Horner syndrome also. The third part of the session, we are going to introduce the Hemi Diaphragms. The Hemi Diaphragms are a domed skeletal muscle separating the thoracic and abdominal cavities. Developmentally, the coastal part and crural part are comprising its total construction, and radiologically it is seen to be normal when it is located 6th rib anteriorly and 10th rib posteriorly in a chest X-ray PA view. The something to be added consequently that the right hemi diaphragm is above the left one is normal. Sorry, there is a printing mistake. I should mention that it is 97% of the population has such normal presentation of the right hemi diaphragm above the left one in 97% population. And the allowable normal discrepancy between a normal left and normal right hemi diaphragm is 4 centimeter. More than 4 centimeter discrepancy of the right and left hemi diaphragm, that is the right hemi diaphragm above the left one by 4 centimeter is pathological, and then we can say this is raised right hemi diaphragm. The left and right hemi diaphragms may retain at the same position in 2% or more or more individuals, and the left hemi diaphragm is above the right one is only seen about 1% or less population. So the thing is, if you have any abnormality in the hemi diaphragm, it is 97 times abnormal rather than a normal only 3% population. And whenever the both hemi diaphragm at the same level, it is 98% pathological. And whenever the left hemi diaphragm is above the right one, it is 99% pathological. So you must be very careful in assessing the hemi diaphragms. Now some slides relating to the hemi diaphragm we can go through. This is a chest X-ray PA view. Why it is PA view? We have learned earlier that whenever there is a PA film, the clavicles will be oblique and the medial ends of the clavicle will be at the uh, level of fourth rib posteriorly, and the ribs are more obliquely placed, and the scapulae are outside the lung fields, etc. We know from all those prerequisites, we can say this is a PA film, I think. It means this patient can stand up. So patient has got no acute condition we can say about. Now, what is here in this film? There is a long fluid level. A long fluid level is seen here under the right hemi diaphragm. And the walls of the thing is not that thin, it is thick wall lesion and has got an air fluid level. And you see that the hepatic mass is continued with this shadow. So nothing is here to be air filled, and the hepatic shadow is basically displaced down because the long hepatic shadow is merged here. So there is an object seen in between the right hemi diaphragm and the hepatic shadow with long air fluid level. And you see, if you go through this X-ray very nicely, and one of the most important teaching you can have that This CP angle is sharp down to the left lateral chest wall. However, it is not purely seen probably, but this is really present, I should say. So the hemi diaphragm reaches the lateral chest wall here. But what you see here, the right hemi diaphragm is not reaching the right chest wall, rather it is lost here. If we recall the development and attachment of the hemi diaphragms, the origin of the hemi diaphragms are separate, different. The height of the hemi diaphragms are different, but you can recall that the insertion of both the hemi diaphragms are the same. On both sides, it should be inserted at the same level, and it will produce a clear acute angle with the lateral chest wall. So anything that producing the loss of acute angle, that we used to say blunting of the CP angle, and that is present here. You can see this hemi diaphragm is lost here. It should reach here, same as this level. You will get the similar level. It is sharply will reach the lateral chest wall. Rather, it is lost earlier, and the CP angle is not that much sharp we used to expect, and seen on the opposite side. Rather, we are having here a possible fluid level. If you can see very keenly that there is a small fluid here and a line over there, over a fluid here. So there is something else with thick wall structure with air fluid level and a small effusion outside this lesion in the right chest cavity. This is the summation of a subdiaphragmatic abscess, and this is small fluid in the right chest cavity, right pleural space, is called the reactionary effusion. Anywhere an inflammation takes place near the chest cavity, like abscess, subdiaphragmatic abscess, any perforation, any chemical irritation from the pancreatitis, is producing a sterile effusion called a reactionary pleural effusion. That is from pleuritis, not from the pleural infection. And the issue is outside there, and the sterile effusion will be present due to a chemical reaction here. Okay. Next, we are describing this slide above we have seen here. The right hemi diaphragm is normal in position. A long, thick walled air fluid level underneath the right hemi diaphragm seen. There is a small right effusion, that is reactionary effusion, and the diagnosis is subdiaphragmatic abscess. And here we see that there is a dense opacity seen in the right mid and lower zones of the right lung field, and this it is taking the contour of a diaphragm, and the hepatic shadow is merged with this dense opacity, and there is possible left-sided mediastinal deviation, a mild mediastinal deviation. It means something else is here producing some mass effect and a continued opacity is with the right, with the hepatic lobe. It means the hepatic shadow is enlarged much more. There, this is not really hepatic shadow because if the hepatic shadow is elevated here, we could get the gut shadow underneath if it is a normal hepatic shadow to be here. So what is this? A dense homogeneous opacity along the right mid and lower zones of the lung field, and the hemi-diaphragmatic contour is seen. There is large hepatic shadow underneath and mild mediastinal shift to left. This is a subpulmonary effusion. Why this is subpulmonary? Because the lung base really takes the contour of the hemi diaphragm, that is seen as a shadow of the hemi diaphragm here, but this is a false presentation of the diaphragmatic contour. This is basically right lung lower surface that is retaining a fluid underneath. And again, I must add that the CP angle is here is not that clean like this. The left hemidiaphragm is touching the left lateral chest 12 nicely, but here it is lost here. It should reach up to this way, but it is lost here. After this, I cannot trace the hemidiaphragm. So the possibility of the subpulmonary effusion is more likely than other else. And you see, if you are very nice to look at, that these are the lung fields seen. Some part of the bronchoscopy markings are seen here. It means the subpulmonary effusion is really underneath the right hemidiaphragm, but some part of the lung tissue is anterior and posterior to the effusion is also present. So this is not at all abdominal aspect. This is pulmonary aspect. The lesion is at the pulmonary aspect, not in the abdominal aspect. So this is not at all diaphragm. If it is diaphragm, then the lung markings should be totally elevated above the lesion. But we are seeing that some lesion, some bronchoscopy markings are running and entering into the shadow here. So this is a subpulmonary effusion. We described. This is a chest X-ray, PA view again. Can you see any abnormality here? This is X-ray chest of an elderly patient. Why we are seeing elderly? That is also a question you may ask. These clavicles has got some osteopenia, like it has got reduced density because it has got some thinning. You see that these clavicular ends and the ribs are thin. This is part of osteopenia, and the medial ends of the clavicle epiphyses are fused by 40 years. So patient is somewhat older patient. And there is cardiomegaly, you see. There is cardiomegaly. And the lung fields are clear. But here, one thing you can notice through the cardiac shadow is a long air fluid level. This large and long air fluid level seen through the cardiac shadow is basically a hiatal hernia. So this is a case of hiatal hernia, a long air fluid level seen through the cardiac shadow is hiatal hernia. We have stated a thick fluid level is seen, thick and long also is seen through the cardiac shadow, otherwise normal chest X-ray, hiatal hernia. And the last slide we are going to present is a case with the left lung is mostly seen to be obscured, and there is a thin elevated left hemi diaphragm. It is seen as a football surface here, that the most of the left lung field is not seen. There is very thin left hemidiaphragm. Underneath the left hemidiaphragm, there are intestinal shadows like gastric shadows, the colonic shadows are here. And by the time we know that the permanent air containing and casting the organic shadows in the abdomen are the stomach and large gut. Of course, first part of duodenum, very little part of the air, little amount of air is seen in the small gut. And this is called eventration of the left hemidiaphragm. Why this is not an inflammatory condition? Because I just want to switch one thing again. I want to make you educate very nicely one thing, that you shouldn't miss a small effusion, because the small you will leave unattended will produce something huge pathology later on. So whenever you are able to declare some small things in early stage of anything, will help the patient, the family, the community, and the state. So you should follow very carefully. Again, the CP angle, this CP angle is clear, and this left hemidiaphragm is touching the left lateral chest wall with acute angle. It means there is no pulmonary pathology and there is no inflammatory pathology in relation to the left hemidiaphragm in the abdomen. So this is a clean-cut CP angle, presents that this is a long-standing condition, no acute matters here, and this is a scenario of the eventration. So eventration of the left hemidiaphragm is here. You see there is inactivity, and the elevation of the left hemidiaphragm produces the mediastinal shadow to be deviated to the right. The cardiac shadow is deviated to the right. Okay, so this is the eventration you may face in your lifetime. And one thing I just want to finish with, one thing, that the eventration of the left hemidiaphragm, how can you declare? It is paralysis of the left hemidiaphragm, and multiple times you will come to encounter one thing, is the paradoxical movement. There's so many entities are seen, will be evaluated in the medicine everywhere, the paradoxical things. Here the eventration presents with the paradoxical movement of the affected hemidiaphragm. Usually left side is affected, and how you will declare the paradoxical movement? It is, what is paradoxical? It is the normal hemidiaphragm gets down on inspiration and gets on expiration, it relaxes, it gets upward. But in cases of even friction, the left hemidiaphragm gets elevation during inspiration, and in expiration it is elevated, and in inspiration it gets down, because when we inspire there is depression of the hemidiaphragms, and on expiration it relaxes. But due to paralysis of the affected hemidiaphragm during inspiration, there is increase in the intra-abdominal pressure, and makes it to be elevated upwards because of the positive abdominal pressure. And whenever you get expiration, patients get expiration, there is elevation of the hemidiaphragm. It causes the opposite direction, because uh, the there is negative pressure seen in the abdomen. And how can we evaluate this paradoxical movement? Definitely you will see it in all those experiments that follows the phases of respiration, like ultrasound, the tomography, and the X-ray taken in inspiration and expiration. You can compare the full scenario. If you don't have any other facilities, you can take the patient's snap of the chest during at the height of inspiration, and next one at the height of expiration. So this is the session I am going to close. No more today. Thank you. If you have got any question, you can ask me.